everyone. Hopefully you're all settled and you have your desserts and your coffee. We're just going to get started here. Thanks so much. So welcome to today's session. My name is Sydney Stewart. I'm a philanthropy advisor with the Edmonton Community Foundation. I'd like to acknowledge that we're gathered on Treaty 6 territory, traditional meeting ground, gathering place, and traveling route of Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. Together, we acknowledge all the many First Nations, Métis, and Inuit whose footsteps we have marked these lands for centuries. On behalf of the Foundation, I'd like to extend our warmest welcome and sincere thanks to you for joining us today. We're thrilled to partner with the local CBA chapter and its membership to bring you what promises to be an informative and enlightening discussion about an increasingly significant topic in our community. And welcome, Colleen. Would you like to say any words?
Sure. Thanks very much for having me today. As Sydney mentioned, I'm Colleen Feehan. I'm the current chair of the CBA Wills Estates and Trust Section North. Every year we are grateful to co-host one session, usually in October, along with the Edmonton Community Foundation. So we're really grateful for that partnership, and thanks for having us today. I'll let Sydney continue on.
Okay. So today's session, as Colleen mentioned, is part of our annual Wills Week initiative, which is now a proud tradition for over 20 years. Wills Week underscores the importance of professional guidance in establishing sound estate plans and supports those who may find themselves in the role of estate administrator. Our goal is to emphasize the invaluable role that professional advisors play in helping individuals and families plan for a future with clarity and confidence. The Foundation takes great pride in being a trusted resource to support professional advisors, like each of you here today, in the vital work you do with your clients. We encourage you to connect with ECF beyond the session today to discuss the role we play within our community or how we can further support the philanthropic conversations you have with clients. Today's session, which you're all here to hear, or here to talk, back up. You're here for the session, not to hear me. There we go. Today's session is on the topic of MAiD, medical assistance in dying. MAiD has quickly become one of Canada's leading causes of death, and in a recent report released this summer, it was determined that Canada has logged the fastest growing rate of MAiD usage in the world following its legalization. Today we are joined by Dr. Boris Enriquez. There we go, got it, with a little accent, a member of the Clinicians Advisory Council with Dying with Dignity Canada. Dr. Enriquez is a family physician practicing predominantly in palliative and end-of-life care, as well as family planning. His appointments include Home Vive, a program with a mandate to provide primary and palliative care at home for frail elderly, as well as medical assistance in dying consultations and provisions for Vancouver Coastal Health, Fraser Health Regions. As a part of his work with MAiD, Boris is also part of Raceline for practitioners seeking advice on patient requests for assisted dying. He also provides medical and surgical abortion care, contraception care, and vasectomy at Willow Clinic, Elizabeth Bagshaw Society, and Options for Sexual Health. He's also recently moved back to Edmonton. So welcome back to Edmonton. Dr. Enriquez, along with a representative from Alberta Health Services, will be fielding questions from the audience, both in person and online, after the presentation. So please join me in welcoming Dr. Boris Enriquez.
All right, thanks for the introduction. And yeah, just to be clear, I am moving back, but I have worked mostly in BC, and as a result, my jurisdictional knowledge is limited. Although MAiD is federally legislated, there are going to be some jurisdictional differences, and we have Carmen Hobbs here with AHS to help facilitate that part of the discussion, including processes, logistics, and then how to get in touch with the team. My disclaimer, I have absolutely no financial obligations to anybody, nor do I have any conflicts of interest to disclose as far as MAiD goes. In terms of bias, I have to admit that I have none that are obvious to me except the fact that I support MAiD in all its legislative iterations. Lastly, that the opinions reflected in this presentation are my own personally. I'm not here as a representative for Vancouver Coastal Health, any of the health authorities, or AHS, or any of the governmental bodies in either jurisdiction of BC or Alberta. So it's just me saying it. All right, so what are we going to be talking about today? So overall, we're going to be having a review of MAiD law. I want to assume that there's a basic understanding, but feel free to interject at any point if there's something I discussed that isn't readily apparent or just needs clarification. We'll talk about the process of assessment and assisted death. We'll have a discussion about capacity, what that means as it pertains to MAiD and how we go about assessing it and understanding it in our patients, and also safeguards in place with MAiD for capacity loss that's current and what's coming down the pipeline. So how the law works, criteria that amount to defense to criminal offenses of both culpable homicide and counseling or aiding suicide. So very important, all physicians and nurse practitioners who work within MAiD are working within the criminal code, which is very separate and distinct from any other area of medicine. What are the criteria? Basically speaking, but we'll elaborate on each of these, you have to be eligible for publicly funded healthcare within Canada, 18 years or older currently, capable of making healthcare decisions. We'll have a talk about what that actually means. Voluntary request for MAiD, that you're not under coercion or that this isn't someone else's idea. Informed consent after being informed of means to relieve suffering, which is part of the assessment process, and grievous and irremediable medical condition, which is where most of the discussion ends up happening. What is grievous and irremediable? We talk about several different definitions which have to be further explored. First, serious and incurable illness, disease, or disability. Advanced state of irreversible decline in capability, so talking about function. Enduring physical or psychological suffering that is both intolerable to them and cannot be relieved under conditions that, very importantly here, that they consider acceptable. The highlights here are terms of suffering. It's a very subjective term. It's not necessarily just a physical amount of suffering. We often talk about existential, emotional, and psychological suffering that occurs because of an illness, disease, or disability. Reasonably foreseeable natural death, what does that actually mean? So one of the biggest things that we try to further elaborate on is what disease would allow for an individual to be eligible for MAiD. Often people would conflate the term foreseeable with imminent, meaning that someone has a prognosis that indicates a limited lifespan within weeks to months, which is not at all the case. We talk about trajectory towards death. An individual has been given a diagnosis that in and of itself means that they have a limited lifespan because of the illness. We don't talk about length of time or timelines necessarily. One of the best examples of this would be ALS. To be diagnosed with ALS is universally fatal. We don't have any effective treatments that would prevent or halt the disease. So that individual is on a trajectory towards death, even though at the time of the diagnosis they might have full function. So who makes these decisions? So this is typically the domain of physicians and nurse practitioners within the country. And in fact, it's both of those individuals that can be a part of the assessment process, whether that's two physicians, two nurse practitioners, or a mix of them making the decisions. It's two independent clinicians. And that could be someone related to the patient's primary care team, or more often, at least in my jurisdiction, someone from the actual MAiD team that's asked to be an assessor or a provider. So this will be interesting for all of you, because to talk about MAiD is to talk about legal definitions, and how we understand MAiD is often a discussion we have to have with our own legal team or with lawyers out in the community. So when we're talking about irremediable and grievous, we're talking about how they're understood within the criminal code. And when we're conducting the assessment, this is the framework in which we use to determine whether or not a patient is eligible. So I like to make distinct separations between the tracks. I think most people understand that more recently, as of 2021, it was introduced into legislation that individuals didn't have to have a foreseeable death to have a MAiD, that you can have a track 2 individual, so that's a patient suffering from a grievous or irremediable medical condition that is not life-limiting, still be eligible for MAiD. But what's a track 1? So these individuals are assessed by 2 independent physicians or nurse practitioners. MAiD is available immediately after the second assessment, presumably found eligible. They express consent immediately before MAiD. That is what we call final consent. So just before the administration of a medication, regardless of when the assessment occurred, the provider is mandated one last time to ask for consent, and the patient must be able to understand that that question is being posed and give permission before a MAiD death can be given. We'll talk about the caveat to that, which is the waiver of final consent, which has enormous implications for several diseases and the patient suffering from them. So what's an example of a track 1 case? So an 82-year-old patient with severe, poorly controlled diabetes, they're admitted to hospital for sepsis, a blood infection that's secondary to a skin infection they got because of poor vascularity. They have to undergo a below-knee amputation that they actually had suffered earlier 4 years ago, but this time on the opposite leg. They're advised by the care team that without the amputation, they're not going to survive. This patient does not wish to undergo amputation associated with the rehabilitation process, even though this would restore possibly function and prolong life. So again, how do we apply these definitions? Serious and incurable, irreversible decline in capability, and enduring and intolerable suffering that cannot be relieved by means acceptable to the person. So when we want to talk about this, now we have to think about what would that mean for someone that's on a track 2 case. It's the exact same process, 2 assessors, except one additional thing. We need expertise in the condition causing suffering. So if the 2 assessors themselves aren't someone with knowledge of that area of medicine, then they can't be the ones providing that consultation in terms of options for treatment. So often that means consulting an expert. A good example of that is chronic pain. Unless one of the assessors is someone that practices in chronic pain, understands all the treatments available, we'd have to go with consultation with a specialist who actually has that expertise so that that patient would be informed of all the options to treat that illness. In addition, they have 90 days from the beginning of the assessment to actually have a waiting period. So even if they're found eligible, they can't move forward right away. They do not have the option of signing a waiver at this point in time. What sort of cases are track 2? So I like to pose similar cases, but hopefully it'll be very clear why they're one is track 1 and one is track 2. This is a much younger individual, 46-year-old, with severe osteoarthritis to both knees. That a result of a lifelong severe obesity and other comorbidities. The patient is refusing rehabilitation and double prosthetic joint replacement. They state that currently they're not appreciating the quality of life that they're having because of their physical suffering, and they're adamant that they would not want to undergo any type of invasive surgery as a result of their illness and are not interested in the rehabilitation or the improved quality of life and function that would result after the surgery, and they're requesting MAiD as soon as possible. Hopefully you can see why those 2 cases are markedly different for us as assessors in trying to figure out whether or not these people are eligible for their MAiD. So interpreting these legal definitions. So what is serious and what is incurable? Serious is very straightforward. For the purposes of MAiD, it's from the patient perspective. What is serious to an individual. How does it impact their life? What is meaningful to them? How does it detract from the joy that they have in their life? How are they suffering now because of this illness? Incurable is the much less straightforward concept. So our central guiding principle is the need for a patient to give reasonable insight and judgment. I'm going to use these words consistently throughout this presentation. So insight and judgment for their decision-making with respect to available treatments. This will be true of many of the definitions we explore. So let's try and apply it. So in both cases of the assessor is determining curability by evaluating the patient's understanding of their options, understand the patient's perspectives on the outcomes of the treatments they are potentially engaging with, as well as the rationale that patient gives for declining treatments. Both cases represent 2 individuals with personal belief systems that are impacting their view on acceptable treatments. The assessor role is to determine if the patient's expressed rationale, taking into account these personal beliefs, adequately satisfies criteria for concepts such as serious consideration and reasonable. And as you can understand, that becomes very complicated. What is reasonable when a patient gives an explanation? So let's go back to the cases. Our amputation patient explains to you that she has already undergone a previous amputation and the rehabilitation was agony for her. She does not wish to go through it again. She doesn't feel she's in a place in her life that she can have the energy and the motivation to see it through, and would much rather end her life now without the further suffering that would result from the rehabilitation. Our osteoarthritis patient states that he suffered a severe complication from a previous abdominal surgery due to a combination of his obesity, hypertension, obstructive sleep apnea, and smoking. He feels the risks of worsened quality of life post-surgery are too great, and he would prefer to enjoy the remaining time rather than risk shortening it with worsened suffering. Are either of these patients eligible based on understanding of incurable? And the really interesting thing to note from this is it'll depend on the person and doing the assessment. Even amongst ourselves, there would be considerable back and forth about the merits of either case and why one would or would not find these patients eligible. Okay. Advanced state of irreversible decline in capability. And I'll just take a quick pause here just to make sure that Carmen doesn't have anything to add and that there aren't any questions. Oh, sorry.
What if two people say, no, you're not eligible? Can that person, the patient, say, can I get two other people to assess this instead because I don't agree with the doctors?
Very good question. Yes, they can. They're allowed to ask for more assessments, absolutely.
So I was reading something in the book this morning about this, and I actually, now that we're in the presentation, I realize I misunderstood something. When it says declining state of capability, just from my legal practice, I understood that to be sort of linked with capacity, so capable in the sense of, are you capable of making decisions? But it sounds like when you're talking about it's actually like capable of day-to-day functioning. Like how is, unless you're going to get to it, how is capability when you dive into the definition of that?
Well, actually, it's both. So when we're talking about capability and function, it's the two are inseparable. So one of the best examples is frailty scales, like how we assess an individual's overall frailty. You know, where are they in that spectrum? We talk about both their mental capacity as well as their physical capacity. For instance, you could have two patients that are clinically severely frail for very different reasons. One of them could have their mentition completely intact, no doubt whatsoever about their capability from a mental perspective, but they have severe osteoarthritis, osteoporosis, two hip fractures, they're bedbound, total care and reliant on long-term care facility to maintain that. If you were to leave that individual at home alone, they would not survive. That's a severely frail individual. Contrast that to someone who's very physically capable, but has severe dementia, has absolutely no short-term memory retention, and is starting fires at home when they try to cook, is forgetting to take their medications. That patient is also a frailty scale that is severe, but for very different reasons. And sometimes it's a combination of both things.
Just one thing I did want to add. So I'm a navigator with Alberta Health Services, and our role is to help guide folks through the process. We also assign assessors and help them through. Just to elaborate a little bit on your question, if we have two no's, so you have been found ineligible, typically from a care coordination perspective, we would require a change in their functional status or in their health history that would allow us to assign someone else to assess them. We know that cases can be complex, so they can certainly have questions about why they were found ineligible, and our assessors are very open and transparent about how they came to that understanding or that conclusion. But I just wanted to clarify that piece. However, with the expansion of MAiD in 2021 that allows Track 2 patients, it's actually quite rare that people are found ineligible. Most often, patients have given this plenty of thought even before contacting us, and there are real reasons why they're coming to our program. So typically what we find is if someone is ineligible, and this isn't always, but most commonly, it's because there is a mental health component, which again, Boris will elaborate on a bit further, but if mental health is the primary reason for them accessing MAiD, that's not currently eligible in Canada.
Yeah, thank you, Carmen. Yeah, it's a really important process and logistical consideration, because when the question is basically a two-parter. Are patients legally allowed to seek further assessment? Absolutely, but from a organizational, logistical, operational perspective, how do we actually do that? We get many requests, at least in our jurisdiction, for mental health patients who are very clearly not eligible, who will consistently request further assessments, and we know that they're going to be continuously found ineligible. So legally, absolutely, but from a process perspective, how do you manage that? And that's going to be jurisdictional.
Going back to that last slide, Doctor, what is your view on eligibility of those two particular patients?
Oh, it's a really good question. So for me, and again, these are my opinions. So the question was, if we were looking at both cases, I alluded to the idea that certainly, depending on the clinician, these patients could be found ineligible or eligible. And the question was, what do I personally feel? Those are two very real cases for me, and both were found eligible. The difference is how you get there. So show your work. The one person I could meet on a Friday afternoon, the track 1 case, and I've seen cases like that many times before. There's no question. I let that person know they're eligible that very day. That other person, I've known them for 3 years now. It took me a year of following them, having ongoing consultation, conversations, consistent messaging, consistent reflection, for me to feel comfortable that this individual has a lot of insight into their life and about why they would or wouldn't do something, and about the risks inherent in the treatment that has been offered to them. But do I feel comfortable? It takes a lot, and to be honest, what is legally allowed and what's comfortable to a clinician aren't the same question, and can have two very real and different responses. But the short and long of it is, yes, both those patients were eligible from my perspective, but it took me a lot longer to get there, and I needed a lot more information, a lot more collateral, a lot more time, and a lot more reflection, which is what we're given for track 2 patients. I always let track 2 patients know, even as I meet them, that I'm not going to come up with a decision the day that I talk to them, that this is going to be an ongoing conversation. Oh, yeah, actually, let's go back to that one. Okay, so when we're talking about irreversibility and decline, so this is another discussion about capability. So what is the actual impact of a disease on an individual? And this is another way that we can further differentiate why someone would be found a track 1 versus a track 2. So for example, the patient that's track 1 has a comprehensive occupational therapist and physiotherapist evaluation showing a clinical scale frailty of level 6. And as we were mentioning earlier, that's how we determine overall how much is this individual struggling with their daily function and the ability to manage their own care. With functional limitations in all their activities of daily living due to the hip fracture, itself secondary to severe osteoporosis. These are irreversible medical conditions. This is a distinct and very robust, frail clinical scale that allows us to interpret and actually make an assessment based on medical understanding and knowledge. Unfortunately, the same is not always true with some of the other conditions. Another illness that patients could apply for with track 2, interstitial cystitis. The same individual might say that effectively because of their disease, they're at home every day, that they have limited ability to manage their own functions, they don't go to social events or gatherings, they don't do exercise, and they're very limited from day to day in terms of how they enjoy their life. A clinical frailty scale would say that that individual is still quite robust and able to manage their own care. So we actually don't have any kind of medical indicators that would allow us to be very confident that an individual left with their illness would not survive it. That individual would survive, although that their suffering is not what's in question. So objective versus subjective. Again, one provides an objective measure, as much as we can have one from a scale perspective, of a disease, its impact, and the outcomes of that. Whereas the other is much more a subjective perspective. We don't have any reliable measures to say, is this person truly frail? It's that person telling us they're frail because of their illness and the way that it impacts them, which is very personal. And again, you can understand why one would be so much faster to get to an endpoint, and the other takes a lot of time to pick and tease apart what is really happening to an individual and what's really happening to their function. Enduring and intolerable. Okay. So like track 1, track 2 patients are experts of their suffering. So when we talk about suffering, I always say the same thing to everyone. I can't know until I ask the patient. And much like definitions of incurable and irreversible, they are not required to undergo treatment options that aim to relieve rather than cure if they do not deem these treatments to be acceptable. This is a very important consideration, the acceptability aspect of it. However, also like definitions of incurable and irreversible, what is acceptable to a patient must be situated in the context of that individual. The easiest way to think about it is an individual with a terminal illness. You might find that a certain patient, given a diagnosis of stage 3 cancer, would be more than willing to undergo the surgery required following the surgery, the post-surgical radiation and chemotherapy. That same illness, that same stage, that same age, that same life in a different person, they might decline every single one of those services and say, I don't want surgery, I don't want chemo, I don't want radiation. And we would understand that that individual is making a decision based on their values and their goals, based on what they want for their life and what they're willing to accept in terms of treatment. And that's the same thing we apply to a track 2, although obviously in a much more complicated way. So serious consideration requires the exercise of decision-making, not only possessing it. So a person could be capable, the best example is that 46-year-old, that patient does not have dementia, they're quite capable of forming a decision, but what I'm really asking is have they used that capability to give me an appropriate rationale for why they would or would not do something. I've had conversations with individuals where it's very clear that they haven't given it due consideration. They'll say things like, I just don't want to do it anymore. I'm just tired of life, and I get much more concerned about that individual having a mental concern, such as depression, that's fueling the cause, and that's actually the reason they're requesting it in the first place, or that they've become so depressed or affected by their mental condition or their grief that they're no longer able to really give due consideration, and they're not in a place to be making these decisions. In other words, a person must display understanding and appreciation of the different elements of the decision, not merely possess the ability to understand and appreciate it. And I have to feel confident that that individual has given due consideration. And that's why time is probably the most important factor in these assessments. If a patient can consistently give me the same reflection, help me understand them better, and I really see that in that individual, I feel much more confident that the rationale given to me has been seriously considered, as well as the treatments that have been offered to the patient. So let's look at two very complicated examples. So serious consideration. We have a 54-year-old with chronic fatigue syndrome and fibromyalgia, very common reasons in our track 2s, and a definitive diagnosis after 20 years of pain and several specialist consultations to rule out other etiologies, like maybe there's something else causing this. No, not in this individual. She's gone through the complex chronic disease clinic program in Vancouver and participated fully in multiple treatment modalities, including medical therapies, physiotherapy, alternative medicine, chiropractic medicine, just everything you could possibly imagine, including mental health. And unfortunately, nothing has alleviated her suffering. Versus another individual that has not undergone any kind of consultation, believes that she has the diagnosis based on her own reading and her participation in online forums. She's read in online forums that the prognosis is poor and that treatments are largely ineffective, so she has not engaged with any treatment modalities whatsoever. She has declined all investigations for other possible etiologies. This is just the beginnings of the discussion. But you can already quite see the difference between these two individuals. Someone who's truly given every effort possible, who really meaningfully wanted to improve their situation, and who is now facing a future where she's been told there's absolutely no possibility of any improvement whatsoever in your pain or your function, versus an individual who really hasn't done any of that. So in summary, from this section, difficult terms with broad interpretations, incurable, irreversible, acceptable. The emphasis on all of these, and I think we've been getting the flavor of that, is that it remains a comprehensive, nuanced discussion with the patient that takes into account their own beliefs, their own values, their goals, and assess their decision-making in the context of these factors and their understanding of their illness. This will determine our understanding of reasonable and serious consideration. So we'll move on to how patients apply for MAiD, which I'm really hoping Carmen can help me with as well. But I'll take a pause again for questions.
that the sophistication and the access to insurance or ability to pay for those things, does that come into it?
Oh, absolutely. So, I mean, any single one of our patients can look up online, and unfortunately, there are predatory practices all over the world that says, oh, we have this amazing treatment that you could do for however many tens of thousands of dollars or more, but you have to pay privately, and we can offer you a cure. For us, we rely on our context. So, a Canadian with accessible care here, what's available to that individual. It has to be realistic, accessible, available, timely. These are things that are important considerations. You know, you can't tell a patient, well, 10 years down the road, maybe this study comes through. No, it has to be situated in the reality of in the context. And in terms of capability, that's part of the assessment. A lot of what I do is trying to understand what this patient knows. My job is essentially a goals of care discussion. What do you want for yourself? What are you hoping for yourself? What are you worried about? What do you fear? What would a serious and grievous look like to you? Are you feeling it now? These are some options available to you. Do you know about this? Have you considered this? Why or why not, if you have? And that's actually what helps me understand a person. I'm starting to understand how they think, why things are agreeable to them or why not. Some patients will tell me, I don't take medications for anything. I don't like the idea of medications. I would never take a medication, and that's just my own personal belief, versus an individual that didn't even know it existed, versus an individual that's been told it's going to hurt them more than it's going to help them. And that's why sometimes those conversations take a long time. It's really difficult to get an understanding of that, the education level, their intellectual ability, their understanding of the situation in just a single conversation. Sometimes I'll leave the conversation, I'll go reread every single consult, and I'll come back and have further questions. Or they'll say something to me, I'll sit and reflect on it and think, that's inconsistent, that doesn't make any sense actually, and I'll go back and try to have them elaborate on what their thinking was and how they came up with that conclusion. So it's exactly that. You really have to understand the patient's knowledge, their understanding of their illness, and make sure that that's being applied in a way that's sufficient for you to find them eligible. Often that's not the case, and it requires further follow-up and conversation. So absolutely we take all those into consideration. But it has to be realistic that I offer. I can't, give them a treatment that they're never going to access and say you're not eligible. Yeah.
Just wondering, when you make your decision, what kind of reasons are you required to provide to the patient? Why you've arrived at your decision about it, eligible or ineligible?
Yeah, that's a good question. And Carmen alluded to that earlier. We don't necessarily have to, but it behooves us to. That's part of the healing process. I find that, and it works both ways. In fact, I probably have more conversations about why I approved someone than why I didn't. Often it's families, it's friends, it's loved ones that are asking me, how is this possible? And I think part of our work is to help families and the patients move forward, as long as the patients allow it, obviously, privacy and confidentiality, to understand what the situation is and why people have made decisions. And it's healing for everyone. It's healing for the patient. It's healing for the family members. It helps with grief. And truly, some patients need to hear it to understand, to move on. When you have your mental health patients coming up and they're being told that they can't move forward with this, it's not serving them. It's not serving the program. It's not serving anyone to just close the door on them. You have to walk them through. You have to sit with them. You have to reflect on it, help them understand why decisions are being made, help them understand the situation from a legal framework, but also from a medical and interpersonal. Otherwise, you're really not doing what I believe is the work, which is to alleviate suffering. And in fact, you could be making their suffering worse by closing a door and not giving them any insight or understanding as to why. And in fact, for many mental health patients, that's what their mental health conditions feel like: a bunch of closed doors and no answers. Carmen, do you have something like that?
Mostly, I think you covered it. I just think the other thing I wanted to add is, like what Boris said, it's subjective. So to kind of go back to your question about what is available to someone, certainly that's part of our role as navigators. Have they been connected with a social worker? Do they even know what kind of financial options are available to them, or additional therapies? Maybe that's not going to solve their suffering, and maybe MAiD will still be their choice, but we want MAiD to be the last choice, and we really want them to have explored every possible option that can relieve them, or even until they have MAiD, let's make those days as best as we can make them. So that's number one part of our role. And just to give you an example, I worked with a fellow who didn't think he could afford it. He was actually not even eligible for AISH because he had such a large sum of money in a retirement fund, but he couldn't access it, because for him that was for later, and he was so worried about not being financially stable as an elderly person, but he wanted MAiD now. And it was hard for me to understand that. Why not access those funds now to make your quality of life better? But again, it's a personal values system, and it's up to us and to our assessors to help them work through that. And maybe that's also connecting them with psychological supports. It's not as accessible as we would like it to be, but there are services that are on sliding scales or low cost. So we really want to make sure they know how to access that.
So what happened with that man?
He was actually found ineligible. He was ineligible because he was not in an advanced state of irreversible decline. He was still functioning in a way that was not aligned with what the assessor thought was an advanced state. And they didn't think that he had really accessed all options to relieve suffering. He hadn't been able to give it serious consideration. So again, he was given a letter outlining why he was found ineligible and an explanation of what we would need to see for him to be considered again.
And just to add further to that, the way that I worded it was we are here to do goals of care discussion, and that's truly how I frame it with my patients. The purpose of MAiD, why we do the work, is to alleviate suffering. That's not to say it's the only or the best way. That depends on the individual. I've heard many different reasons for why somebody would want a MAiD, and often it can be something that we can address without having the assisted death be at the forefront. I've been to assessments where someone tells me they're just in a serious amount of pain, and then I find out they're not connected with palliative care in the community. Suddenly they're connected with palliative care. They go on more because they're feeling much more comfortable at home. That person can ultimately have or not have a MAiD death. I have many examples of patients who receive palliative care and die comfortably at home, many who receive palliative care and end up requesting MAiD. For me, it's not important what the end decision is for them based on our discussion. Do you choose MAiD or do you choose something else? I don't want that person to suffer, and I want to make sure that every option is available to that individual. And so our job in that goal is to make sure that all the options available to alleviate suffering are presented, are available, understood, and then that patient makes a decision about what's best for them. Some people aren't afraid of pain. They just don't want to be sitting in a bed. Some people just, in a hospital bed waiting. Some people are just suffering from extreme nausea that's intractable. Some people just can't bear the thought of them not being awake or present on their final day with their family. There's a million reasons why someone would be afraid of a particular end or why someone would have concerns for suffering. And our job is to understand that and see if we can offer anything to alleviate that suffering. And sometimes the only thing we can offer is a MAiD, but certainly we explore all options. So process overview. Oh, I'm so sorry. I don't think this was supposed to be an animation, but here it is. All right, patient inquiry. Request for MAiD. Minimum of 2 assessments. Assisted death. After death care. And see, this is important. And this is inseparable from the care and why I was alluding to it earlier. Part of the work we do is talking to people after. My job, at least from my perspective, doesn't end the minute I've pronounced that individual. A lot of the work comes afterwards. It's helping people grieve. It's helping people move on. It's making sure they access resources. Our coordination office, and I'm quite certain AHS as well, has a lot of these resources available to patients and often connects with patients after to check. And I have many discussions with patients' families afterwards to see how they're doing. Continuous care. So the initial patient request, this is going to differ jurisdictionally, but essentially the process is, identical. The patient makes a request. It doesn't have to be a consultation from a physician or a nurse practitioner. So it's not typically like, I want to go see respirology, I need to talk to my family doctor, they need to do this referral. This is patient initiated, so individuals can write the request, send it into their coordination office, and have somebody witness. The assessments, depending on that patient's, primary care team, it could be someone from the inpatient team, it could be their family physician or nurse practitioner, primary care. It could be a specialist involved in the illness causing them grievous and irremediable suffering, like their oncologist or their respirologist or cardiologist. But very often it's 2 assessors from the MAiD coordination team, and the coordinator is trying to facilitate that connection. And we already answered that question a little bit, about the additional assessments. So the MAiD process, found eligible for MAiD, we separate them into either foreseeable death track 1, non-foreseeable track 2. We've already talked about some of these safeguards, whether or not they have a period of waiting that they have to have, whether they can sign a waiver, and whether a consultation is needed. And then ultimately, a patient selecting a date and time for their assisted death. And like I said earlier, that's not necessarily the case. An enormous proportion of my patients never reach out to me again, or I follow closely and they die comfortably in some other way. I'll stop there for a moment again, just to make sure there's nothing else to add. No questions? Okay. Understanding capacity. Okay, so what is dementia? Dementia is a neurodegenerative disorder affecting an enormous proportion of the population. It impacts your capacity to make healthcare decisions, especially even early onset and early stages. Interestingly enough, it's in the DSM-5, but for the concerns of MAiD, it is not considered a mental health condition. It does allow for a reasonably foreseeable death, but we'll have a discussion about that. That's jurisdictional as well. I know that in BC, many of us would find our dementia patients track 1. That's practiced very differently in many other jurisdictions. A lot of the times, individuals will be found track 2. It depends on the rationale and the thinking of the clinician making the decision. And we'll talk about how that might impact somebody. Waivers of final consent, very complicated when it comes to dementia, and we'll have a chat, especially when things are getting to the end stage of the illness and we're really seeing some functional decline. So what is capacity? A patient has the capacity to consent to treatment if they can understand the nature of the treatment, its anticipated effects, and the consequences of refusing. And all of this is inseparable from their illness. This means a patient must be able to demonstrate insight into their illness. What is it? What is it doing? The impact the illness is having on their function and quality in life. How am I affected by this illness? Not just how it affects others, but how me personally am impacted negatively by it. And also understand the options for the treatment, including the risks and benefits of these options. The patient must then be able to operationalize this insight to form a reasonable judgment based on their values or beliefs. Now that they understand what the illness is, what it's doing to them, why they personally are suffering from those impacts, and why the treatments, if there are any, are unacceptable to them. Comparing levels of understanding. So here's another example. So an 89-year-old patient with severe dementia in long-term care facility repeatedly shouts to all staff members that she wants to die as soon as possible. When interviewed, she will not answer questions posed, but simply repeats that she doesn't want to live and she just wants to end her life. A 99-year-old patient, contrast, with severe dementia explains to you that she has been told she can no longer remain in assisted living because of her poor memory, which poses a safety risk. She's a retired physician and worked in long-term care facilities and explains she knew she would never accept this level of care. She is aware that she has the right to seek further levels of care, but declines these in favor of an assisted death, which she has already discussed with her family. And so the important impact here is to understand why this illness with this individual is so detrimental to them. In fact, I've seen both cases. As I was mentioning earlier, part of my work is in the community with frail elderly who want to remain in community, and we do as much as we can to keep them there with assists, resources, personal home care, supporting families. For these individuals, remaining at home and seeing their disease to the end is incredibly important to them. For others, I'll meet them in hospital much sooner in their trajectory, maybe even the same illness, and they tell me that they don't want to do it anymore and that they want an assisted death. The important thing here is understanding the individual, which is why we have to have that conversation. What about this person is impacted by this illness? How does this illness then fit into this individual's life? How is it interpreted? How is it experienced? And that's something only the person you're talking to can answer. So the waiver of final consent, what is it? Only for people whose death is naturally reasonably foreseeable. It's arranged with an individual MAiD provider. That means this waiver isn't applicable to just anyone. It's something signed between a specific physician or nurse practitioner and that patient. A day must be specified on that waiver for a provision, meaning that it's not an advance directive that gives instructions under certain circumstances. It's specifically a plan to move forward with a provision, with the caveat that if capacity is lost within that time frame, that they've given permission to move forward. It's not binding in that if that time frame comes along and that patient decides they no longer wish to move forward, they don't have to do anything. An essential component of MAiD is that you are absolutely never obligated, which is the reason for final consent. Up until that last moment, a patient can decline and change their mind. You have to give it at least 1 day after speaking to the patient. So you can't sign the waiver and then use the waiver on the same day that you sign it. The person does not demonstrate by words or gestures that they're refusing your care. An incredibly essential component of this that we'll talk about in our cases. So for instance, if an individual signs a waiver, loses capacity, and I arrive to provide them assisted death, but they refuse, I can't provide an assisted death, that's not an option, that's a mandate, and actually something we have to fill it in a form that is binding. So a good example of that was one of my cancer patients became septic, a really bad blood infection, and she was acutely delirious. She had absolutely no idea what was going on, where she was, or what was happening. And very end stage, there was no curing this. It was the very last stages of her cancer. But in her delirium, she was quite aggressive and actually started yelling at me and asking me to leave and not to come back, even though I knew it wasn't truly her talking, that she was confused, and I knew that this was the end of her life. I had to go. There was absolutely no option to provide the assisted death, which she asked me to do. Okay, applying. I think it skipped one. Yeah. So now we're just going to take some cases and apply things. These are some examples. I have a million of these examples, so feel free to interrupt. This is more of just like the back and forth talking component of things. Any questions before I start giving you examples? Okay. So Betty, 79-year-old female with remote ischemic stroke, 2 years ago, living at home with daughter, who is the main caregiver. Over the last few months, she's been having more frequent falls, struggling a lot more at home with her ADLs, and finally lands herself in the hospital with a hip fracture. She has difficulty with expressing herself due to her stroke, so expressive aphasia, but she's able to follow along with the conversation well. Her understanding is, intact, and her daughter really does help with some of the communication because she's so used to having to help her mother and assist her with that. The patient has selected a specific time and date for her MAiD, and she's quite clear about what she wants and when she wants it. So stable with sudden risk of capacity loss. So in a vascular dementia patient, that's typically what happens. They'll have a sudden event, they'll have a functional decline, but then it stabilizes and that individual maintains that level of function for an indefinite period of time until the next insult, and they're at high risk of another vascular event, whether that's another stroke or a cardiovascular event. This particular individual has some protective factors in terms of making sure her capacity is intact and that her wishes in the end will be honored. She has known risk, she has signed a waiver, she has set a date, and has a reasonable timeline for the date. The longer you go, the more likely you are to lose capacity. So this person is likely to move forward with her assisted death wishes with limited complications. This is like a low-risk waiver that I'd sign. Let's look at Samantha. This is a 72-year-old retired nurse living independently. She is early in her dementia, but is adamant that she has already made a decision on an assisted death. Although she's hopeful that she's going to have a little bit more time, she's not nearly ready. It's still early in the disease, and we don't know how it's going to progress. She has a clear threshold in mind. She does not ever want to have to move from her home. She's spent her whole life cultivating and building it. She has a beautiful cherry tree outside that she absolutely loves, and she wants to live and die in that home. And she would not want to continue if she couldn't remember her granddaughter. These were two very distinct, important thresholds for her, things that were absolutely non-negotiable. And so what are the things here? I always talk to patients about thresholds. What are you afraid of? What is suffering to you? What do you not want? What would you not accept? For some people, these are very distinct and we have them in mind. And for others, they're a bit more nebulous, and in fact, we don't really know them until they've happened. And then you don't know what you've got till it's gone. Very real for a lot of people that once you've felt a loss because of an illness, then you really understood what it meant to you. But I always like to try and get people to think about these things, especially when it comes to dementia. And we just don't know how quickly she's going to decline, how severe it's going to be the next time I see her. But the threshold really helps. And this is the reason why, when I'm talking to a patient and I sign that waiver and I ask a patient, when do you think you would want to do this? they're really telling me what level of suffering would be intolerable to them. And they're telling me what suffering means. And it helps me understand what's the relevant parts of a conversation. This becomes incredibly important when this person has a lot more difficulty having a conversation. At some point, this same person is going to have difficulty connecting concepts. They're going to have difficulty remembering what it is, you said or did. But what they will not forget, one of the last things to leave people are the things that are really profoundly part of that person. Memories retained, that talk about personality, values, and beliefs are some of the last things that a person loses because of their dementia. So when you have a clear understanding of what that is for a person, and you have a clear understanding of what you can express in terms of the functional losses that person has endured, because they might not remember, that person, then you see it in their faces. They actually give you an expressive display of what they're feeling once they know what they've lost.
Question in the back.
Please.
When you say clear date, how far ahead?
That's a very good question. The answer is it depends, and Carmen will talk about this a bit too. So the waiver is the best instrument we have to safeguard against loss of capacity, but it's not a perfect instrument. And in fact, what's happening now, and one of the articles that was alluded to earlier, is that we need something maybe a bit more comprehensive. And the discussion now is about advanced directives because of time limitations and the limitations I've just discussed. Every single person that practices MAiD is going to have a different understanding of how they utilize a waiver and the time frame in which they feel comfortable using it. When it first came out, maybe we'd use it for a few weeks or a few months. Now the current practice seems to be most people feel comfortable signing up to a year, specifically with losses that are a little bit more slow, late in their progression. But that depends on the individual. Some people won't sign a waiver for longer than 6 months. Some people don't sign waivers. I've never seen one beyond a year, but there's really very limited direction on that. It's not like we have clear guidelines for how to use them.
I would like to pick 2056 for myself.
20, well, yeah, exactly. What you've just asked for is an advanced directive.
So would it be that if somebody signs one of these waivers and they get to the day and they still do have capacity, can they just make a new waiver? Is that sort of what happens?
And you've just discussed the evolution of the waiver. So what's been happening is exactly that. People are afraid of losing capacity. And again, this is something I'm seeing in BC. They get to their date and they still feel able and capable. They're still functioning well, they're still enjoying their life, and they want to continue. And as I mentioned before, nothing happens until a person says, today's the day, now's the time. And so we'll re-sign the waiver, understanding that that conversation is probably different than the one you originally had, and capacity is certainly more impacted, depending on the disease. I always use, for the purposes of this discussion, I'm using dementia as the example, but obviously that would be different with a different illness. But exactly that you can re-sign the waiver and extend it, or replace it.
What happens? Do they come into your office on the date that it was supposed to?
Oh, you've given another example of how things are getting complicated. So I've been practicing in MAiD since 2019. I used to have maybe, as of 2021, a couple waivers in the community. Now what's happening is people understand the waiver. And this is the thing, people educate themselves. They understand MAiD, they understand what their rights are, they understand what is available to them, they understand from their friends. I've even gone to facilities where everyone's talking about it, and they talk to each other about, hey, you can have this thing that protects you against, if you have a really bad fall. And people are requesting it, and now it's becoming incredibly complicated to keep track of all these waivers, to understand whose waiver is due. And now you're talking more jurisdictional and program specific, because even within a jurisdiction, there's different programs. I'm not entirely certain of the Alberta experience. I think there's like a North, an Edmonton zone, a Calgary zone. But in BC, we have health authorities, and we have several of them. And all of these health authorities have their own specific MAiD programs, and all of these MAiD programs have their own specific ways of dealing with this. And this is why there's the further discussion about the advanced directives is becoming very clear that Canadians want, and again, my opinion, some way of protecting their capacity and their right to access MAiD, even though they're not ready to make a decision, nor may they even be ready to be found eligible. And so the discussion has been around these advanced directives and how patients can give permission for the future that they don't know anything about and that we can't inform them about.
So what you're saying is, currently right now, if you have a date set, if you become incompetent before that date, you can't follow through with it because you have to be able to give permission at the time.
you're working on the possibility of, or the association is working on the possibility of advanced directives that will allow them to lose that capacity and still have that date followed through on?
Not quite, but close. So what I'm saying is, number one, if you lose capacity and you do not have a waiver, you've lost MAiD. You need to be able to consent and provide final consent on the day of, unless you have a waiver. The best example of this is, let's take a cancer patient. This person goes into a coma. They're no longer awake, they're no longer functioning, they have a waiver. And my express instructions were, arrive as soon as possible once I lose capacity and provide me an assisted death. The waiver's in place. It isn't quite their date yet, like they picked 2 months ahead of now, but capacity's lost and it's not going to come back. I have a conversation with the team. If it's a UTI and they're delirious, that's reversible. Maybe we'll get back some capability. They're in a coma because of mets to their brain and a metabolic derangement that we can't fix because of their cancer. They're not going to regain consciousness. I provide an assisted death. The third example was the one I told you about the delirium. That patient tells me to go away. They've lost capability, they have no capacity, they have the waiver, but they're resisting. They say they don't want it. I can't do it. I can come back another day and see, if that patient's still alive and try, but as long as that timeline's in place. But once the waiver expires, then you go back to the original. The waiver's expired, there's nothing in place, they can't give permission, you can't do MAiD. The discussion that people are having now is more about an advanced directive. So what is an advanced directive? Let's take a step back. If someone's doing a goals of care discussion, they're talking about what they would want in terms of their level of care if something adverse were to happen. A good example of this is if they have a cardiac arrest. What would I want to have happen in the event of a cardiac arrest? Some people want full resuscitation, chest compressions, intubation, go to ICU. Some people would say, I don't want any of that. If my heart stops, just let me go. An advanced directive is when people start to give instructions specifically about their level of care in the future. What would you want? We don't have that for MAiD yet. You can't instruct somebody when to provide you an assisted death under what conditions. It's very specific to a particular illness and a specific outcome, which is loss of capacity. And so that's the discussion now. How do we incorporate, if possible, advanced directives? The recommendation is there, but how we navigate that is an incredibly complex issue, way above my brain. And it's going to take teams and experts and consultations and task force to figure out how we navigate that. Because, someone made the joke, but it's very real. 5 years from now, 10 years from now, 20 years from now, how do you interpret that document? And people already struggle with the idea of MAiD, with their loved ones now, and they have a serious illness. How do you navigate that if someone's putting on their advanced directive 20 years from now? So very complicated questions that people are trying to figure out.
So what happens where you get to the stage, the person's lost capacity, they have a waiver in place, the date scheduled is coming up, and the agent says, well, mom's lost capacity, but the family's not ready yet, because even though she's lost capacity, we still want her around a little bit longer.
Oh my God, you've segued beautifully into one of these other cases that's coming up. So I got a story for every situation you can come up with. I'm telling you. So yeah, it's a good question. Let's hold on to that for a second. Okay, let's just do Gertrude, and then I promise I'm going to answer that question. Gertrude, 82-year-old female with new diagnosis of dementia. She's currently functioning well at home while living with son. She states that she would never accept having to depend on her children for daily living support and would want to move forward with an assisted death if she ever required such care. She does not have a clear idea in mind of what level of severity would prompt her to request MAiD, but she feels she will know it when it's time. It's happening. So no threshold, no dates, no timelines. We're getting into nebulous waters here, which is, advanced directive, or is this a waiver? This patient is at high risk for capacity loss due to multiple factors. We don't understand what her end goal is. We don't understand what her wishes really are or what they would look like. When it comes time to make the decision, it's really hard to navigate. Have we reached a level that you wouldn't appreciate? And her ability to inform you of that and have a meaningful discussion of that is every single month going down. Like, this disease is progressing, her insight's slipping, her judgment around that insight is diminishing, and you're trying to have a more complex and nuanced discussion of these are the impacts, these are your functional declines, and you really can't understand, and that patient's ability to help you understand her and her wishes are diminishing as well. And then it comes time to re-sign the form, and you're losing your confidence that this patient really truly understands that concept. And I think the next one is our, yes. A 67-year-old with severe dementia has been followed by her MAiD provider for 2 years. She was clear at the onset of her application that her threshold for a MAiD death would be admission to long-term care. She's now severely impacted by her illness and can no longer remain home safely with her elderly husband, who is main caregiver. Unfortunately, her insight is severely impacted, and she does not realize how severe her disease is. During a family meeting, she turns to her husband and asks, "Is it really that bad?" Her husband states, "Not at all. You're okay at home with me." So this is probably the most common and the most difficult to navigate. It's familial support and honesty. You know, once the disease has progressed significantly, that patients will have to rely on family for accounts. They don't know that family's waking them up every morning to take their meds and get dressed. They don't know that all the handles have been taken off the oven because they started a fire last week. They don't know that the watch they have on is actually GPS, and that the community gate is closed, and that if they wander off, the family has to retrieve them and bring them back. They don't remember any of this. And so these individuals then rely on family and you to help them understand. You know, I like to be clear here. They're not seeking advice on whether they should or should not have an assisted death. That's the patient's domain and only the patient's domain. What they're asking is information that they need to make a decision about their beliefs and values. I've sat there with patients and I've told them, no, it actually is as bad as, you know, it could be. I tell them all the things that are happening. And a patient, and that's actually what happened with the patient in the threshold who told me about her granddaughter. The day came, I looked at her, I was sitting there with her sister, and I said, "You don't know who this person is anymore." And I showed her the photo. And she was shocked. She's like, "I had no idea that I'd forgotten my granddaughter." And I said, you have. And this is only going to get worse. And she made the decision. She's like, "I knew I never wanted to get to this point. This is too much. I don't accept this. I really want to move forward with a MAiD." And we were able to have the conversation because we understood the threshold. We understood what was important to her. We were able to provide the information that she needed to make a decision. Capability is still intact. She understands what's happening. She understands the severity of the impact, and she can express to me why personally that is not something that she's willing to accept. But we've gotten to a really, really endpoint. Please?
So are the thresholds you're talking about built into the waiver, or is that just something in your practice you utilize?
Oh, it depends on the person. Sometimes people will, there's actually a whole space on the waiver that talks about special things that the patient would like to put on. I've had patients write that I really wouldn't want a MAiD provision to occur during the summer months. I really enjoy all these things that happen. I would want it to be, you know, in the fall. Patients can be quite, you know, detailed in what they would want or not want, but most of the time they don't sign anything. It certainly is, but it adds another level of complexity and difficulty, especially with familial concerns. You know, a lot of the and this is why I like patients to be very clear. It helps me navigate these waters. I've had patients tell me, "Give family some time to be present for my MAiD provision. I have family across the country. I wouldn't want you to just arrive in a hospital and do it. My family is important to me and I want them to be present. But I also need clear guidance. If family's telling me, we're not ready yet, we don't want this to happen, the only thing I have to guide me, and the thing that is my mandate, is my patient's wishes." And I'm very clear with families about that. I understand grief. I understand suffering, personally and professionally. But I understand that when it comes to making a decision, the only person that can direct me is the patient. That's the purpose of a waiver. This isn't like any other area of medicine where you can have a substitute decision maker. If this was any other condition and a person ended up in the ICU, family caregivers would be consulted about what's the next medical condition. No one is allowed to do that with MAiD. That is absolutely clear, and that's never going to change. There's no substitute decision maker. The patient has to tell you. And so that's where I get my direction from. And so the short and the long answer of it is no. If a family tells me, and again personally, that they don't want me to do this, I will still do it. I've had even families struggling and saying, I think she's going to die naturally. Just let her go. And I said, I can't. This person knew that they were going to die naturally, and they specifically told me if they lost capacity not to let that happen, to come provide a MAiD. Even though that causes grief and suffering to the family, even though my patient would never know the difference, that's something that they instructed me, and that's my mandate. I'm here to fulfill the patient's wishes. And it gets very, very difficult to navigate, but that's why I talked about healing and grief. I would still have the conversation with family. I would still talk and reach out. We navigate this water together. And I have this discussion with the waiver when I'm talking with the families. This is very explicit. I get everyone around who's allowed to be part of the conversation, and we're all discussing what the waiver is, its implications, the power that it holds, and what it takes away from the family in terms of decision making.
So just to be clear, if a patient has signed a waiver, and then they lose mental capacity, so they have a date 2 weeks from now, they lose mental capacity, their personal directive or representation agreement is triggered, somebody is making their decisions, that agent or that person named under their representation agreement on the day 2 weeks from now can't say, go away. Are you going to agree with this?
They can't, no. The waiver supersedes everything. From a legal standpoint, what the waiver is saying is that I've been given permission to provide an assisted death as soon as the patient would deem it, and most patients would say as soon as possible, if capacity is lost. In that event, yeah, no, there's certainly been people, and I've had those discussions, they'll tell me I'm a representative, I don't want this to happen, and I have to explain to them, I understand the representation agreement, but this document gives me permission.
Yeah, because I've always told my clients, nobody can ask for it on their behalf, but I've never told them, nobody cannot do this.
Oh, I'm very clear about that. I say that exact thing to families. I say the form is powerful in two ways. Number one, it gives you absolute authority and decision-making in terms of this outcome. And number two, it takes away decision-making from anyone else that's a substitute decision maker. The form's not concrete, mind you. Some people sign the form and tell them all the same thing. You can take the form away. You can call me and say, invalidate it. I don't want this form anymore. And the form is taken away. And I always give patients the opportunity. You don't have to sign the form today. If you want to give it due consideration or talk to your loved ones about it, here's the form. We have on our website instructions on the form, how to use it, how it's operationalized, what it means, the implications of so, and you can call me at a future date. Or some patients are very clear. And in fact, they do it for the opposite reason. They're actually intentionally trying to take the decision away from family. They understand what might happen if it becomes time for children or spouses to make decisions. They're saying, no, 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 no. I know what I want for myself. I don't need this informed by anyone. This is what I want.
So, do you ever work alongside death doulas?
You know, I've been seeing death doulas much more often now. Yeah, it used to not be the case, but now I've met actually quite a few. Yeah, very much so.
So in the case of a client or patient, whatever you like to call them, where they've signed a waiver and they lose capacity before that date, even though they want you to come as soon as possible, you're relying on the family to know about that waiver and enact that.
Yes. So not always, but in complicated, but ultimately yes. So I always tell people this, because I have a story for everything. There was an instance where, you know, I'll never forget her. This was one of the first patients I ever signed a waiver with. They lived not close. You know, I had to take, you know, a ferry over and all this stuff. And she's very clear with me. She's like, the thing that she was most afraid of, she said, one day I was in a hospital for something unrelated to the condition she saw me for. And I saw this person next to me that was dying for a week. Family, friends kept coming in, but this patient was just unresponsive. She never regained consciousness, and she died. And for the full week, I just saw family being there, sitting, talking, and just no interaction. She says, that's my biggest fear. I never want to be there, but not there. I want to say goodbye. I want to know they're there. I want the last image they see of me telling them I love them. And she told me I never want that to happen, so I'm going to sign the waiver, and if at any point I lose capacity, you come as soon as possible, you end it. You don't let me go through that. And I said, of course. And I learned a hard lesson. I one day got a phone call from a nurse that was a palliative nurse that was in with a patient saying, yeah, I think this patient's lost capacity, but I think she's gonna pass tonight. And there's just no way. I was on some other different direction. I said, there's no way I'm going to be able to get there for another 2 or 3 days. And I asked, how long has she been like this? And she said, oh, weeks. And I was in shock. I'm like, oh, why didn't anyone tell me? And I found out. I spoke later with the spouse, and they were very clear. It's like, oh, I wasn't ready. I didn't want to. That person had relied on family to notify me. And so from that moment on, and again, we'll talk about that. There's nothing malicious here. I always give a little bit of patience and understanding in these circumstances. But what happened was that the family member wasn't ready, and that family's member's wishes were honored, not my patient's. And so now I have the very clear discussion. You won't be able to tell me you've lost capacity. You need to entrust that to someone that you know was going to call me. Sometimes it's inpatient teams, sometimes it's, community members, sometimes it's someone else involved in their care, but almost always it's family or a friend. And I say, you need to have a discussion with this person, you need to make it very clear what your goals and wishes are, and you need to be assured that you're placing your trust in someone that is going to make that phone call. It's normal and human to struggle to make that phone call, so then I have that conversation with that person as well, and I say, hey, you're not calling me to end this person's life. You don't have that power. You can't tell me to do anything. What you're calling to tell me is that this person that you love has lost capacity, and that her wish was that I be notified when that happened. And then I can arrive, and then I make the assessment, I determine capacity, and I make the decision to provide an assisted death.
So this may be an Alberta question, but should we put a copy of the waiver in the green sleeve?
Good question. So, very good question. And I will speak a little bit to the practicalities of how we perform MAiD and the waiver in Alberta. But exactly what Boris said, we do make sure that, number one, patients entrust this to another person. Documents get lost all the time in green sleeves. My background is ICU, and I can tell you, I've seen it before, sometimes goals of care are not even honored. If you have a goals of care that says no ICU admission and you present to emergency and cannot speak for yourself, if a family member says do everything, that team will do everything. Absolutely. So that can be very distressing for healthcare providers who want to honor wishes, hence why I now work for the MAiD program. But just to speak very practically to how we interact with patients in Alberta, I encourage folks to not apply for MAiD until about 3 to 6 months from wanting MAiD, because number one, you have to be a track 1 patient to even have the waiver be an option for you. There's always risk with practitioners not being available, so that's another thing that we need to make sure is very clear. Especially, we cover all of northern Alberta, so in Edmonton we're very lucky. We have a large group of MAiD practitioners. We have good accessibility. If someone's going away on vacation for a month, we will ask someone to step in and perhaps do an alternate waiver so that that person has backup while that person's away. In northern communities, we are lucky if we have one person who covers a large area. So we have to be very clear with folks that yes, we have this waiver in place and we will absolutely do what we can to honor your wishes. But if Dr. Smith, who covers whatever area, is on vacation out of country, we have to wait for that person to come back. As Boris said, that's a contract with that person and no one else can step in on their behalf. So it has happened where a wish wasn't able to be honored, or even we're notified with very limited amount of time. In Edmonton and northern Alberta, we ask for at least 3 days notice from a scheduled provision or even from initiating a waiver. Sometimes when folks lose capacity, we don't have that kind of time, but if we're notified on a Friday night or a Saturday night, pharmacies aren't open, we don't even have access to medications, we might not be able to arrange support, the physician or nurse practitioner might be working 12 hours in emergency, there's lots of considerations. So that speaks to the Alberta sort of experience. Again, with that 3 to 6 month time frame, knowing that you're never held to it. We never want someone to feel encouraged to go ahead with MAiD, but that's also why we don't ever reach out to patients. So again, when speaking to a re-signing of a waiver, we always tell folks, it's up to you to call us. So if you have a waiver signed for January 30th, and you're still feeling well mid to late January, I say, please call me. We'll happily extend this waiver or sign a new one with that practitioner, but we won't be calling you. We don't want you to ever feel pressured to do so. This has to be an individual decision. So with dementia, of course, it gets more tricky or with any condition where maybe there is a life-limiting nature to that disease, but the prognosis may be long. So that's where things can get a little more tricky. And again, we rely on our assessors and providers to be clear with their sort of boundaries on the waiver. I have providers who will not sign a waiver unless it is a specific date for MAiD. But some folks approach it more like an expiry because there is never any obligation to follow through. So we do try and pair providers with folks and take into account that threshold and take into account what's important and match them with someone who has similar values. But of course, there are limitations to what we can provide.
So just one comment from a practical perspective. People can't even remember their hair appointments, let alone the expiry date of their MAiD waiver. So maybe there should be some sort of system in place where it's not to force them to come in, but just as a reminder a week or a month before that it's expiring.
And some practitioners will do that. So again, we leave that up to that person who's actually putting their name on that document and is going to be held to that wish of that patient. So we do have practitioners who will follow up, and that's their mandate, but we have ones who don't. And we do our best to just respect that provider's approach to that waiver and to the patient wishes.
Do you have a sense of what the rationale is that it's a waiver with one physician only? Like, why can't it be a blanket waiver, for whoever may be able to conduct the procedure?
I'll throw this one back to Boris, but one thing I just want to mention, and I think it speaks to the personal directive side of things too. If I'm a MAiD provider and I've never met you, and someone asks, hey, can you go provide MAiD for this person? I might not have even had a chance to review your medical file. I might not know exactly why you wanted MAiD in the first place. When we think about what MAiD actually is as an assisted death, it is an incredibly intimate experience, and it's a very big ask to ask someone to end someone's life, especially when they hadn't had that conversation. So personally, I think that looking at personal directives is very important, and as Boris said, we need to honor what Canadians want, but there are so many nuances and intricacies that we really need to consider. So if I have a personal directive that says I want MAiD if such and such happens, and then in 15 years, such and such has happened, who's gonna make that decision for me? Someone gonna pull me out of bingo and say, Kate, today's your MAiD day. We have to joke because we work in death and dying, but I think it's really important to think about who's making these decisions and when do you enact those. And yes, you can lay it all out as perfectly as you can on a piece of paper, but when that actually comes into play and practically when that happens is very different sometimes.
And so then it's you as the individual physician who has the waiver making the decision as to whether these thresholds have been met, I guess, right? And you're doing that with the knowledge of your prior conversation with your patients, I guess.
Yeah, that's exactly it. That's why, it's precious work we do, Like the person that I was just describing, I'll never forget her. I'll never forget that phone call. I'll never forget that meeting. That's not the case with all our patients, but there's something really personal exchanged at that moment, and that's something I know about her, That's something that connects us. That's something that guides me. That's the only guide I have, is what my patient tells me. And it's like Carmen said, there's something very personal and momentous about that moment. I'm ending someone's life right there, and I'm asking them permission to do it. And you never want to lose that, at least personally. And it helps guide conversations with families, the work that comes afterwards. If I don't know this person, I don't understand what they told me, family's going to have questions, and I can't inform that conversation. That takes away the healing component. That takes away the understanding. So there's the personal nature of it, that intimate nature of it. That's really important. As a physician, I feel that's my goal. I'm in service to people, and I need to be in service to that individual, and I need to know that person. Then there's the other part of it, which is much more about consequences. Like I was mentioning earlier, this is criminal code. So if you do something that's unlawful, you're criminally prosecuted for homicide. That's the consequence of doing a MAiD without legal precedent to do it. And imagine you're doing it based on someone else's assessment, someone else's decision making, and you're taken to court by the family. How do you defend that? How do you say this person did lose capacity, this was their wishes, that they were eligible? You get into a lot of legal ground, and you don't want to get into that complicated nature. You want to be able to know what you're doing confidently is lawful, and that you've had that conversation. That's kind of what I was mentioning about track twos. I still have felt uncomfortable ending the life of a track two. It still hurts. You know, I feel grief. I feel fear. I feel all these things when I'm doing it because I don't want this for this person. But legally, they're entitled to it, and I feel bound by my role as a public servant, and I'll do it. But I need to be confident that I'm doing what is the right thing to do based on the law and based on this person's wishes. And sometimes that takes like 10 conversations. And so that aspect of it too, and if I were to ever be asked questions about it, whether that's in a criminal proceeding in court or to the family member, I want to be able to say exactly what my thinking was, why I did it, how I felt about it, and who that person was. And so yeah, those are the personal aspects of it. I think there might be some movement interchanging assessors, because that's a good question for assessors. If two people have assessed this patient, why not just bind them both with that waiver? Because they both obviously feel comfortable finding them eligible, but to have an outsider come in, I think would be probably impossible, even in the future. Sorry, and then you next.
So going back to the waiver issue, so would it be productive in a power of attorney, or sorry, a personal directive, not power of attorney, in a personal directive to offer a client a statement that in the event that I've got a waiver or advance directive, I direct my agent to comply with it? Is that a useful?
I mean, if they could find somebody that's unbiased and that's not personally and emotionally impacted by it, it always helps. I think even if I have the conversation with a patient and I say, your family member's not telling me to end your life, they're just informing me that something's happened, it's still hard for that family member to pick up the phone and be like, something's happened. If you can entrust it to a legal representative, somebody who will be unbiased and just, you know, read your wishes and perform in their duty, I think that's always, you know, a bonus. But it's hard to know how these two seemingly inseparable but very operationally separate silos function. You know, how does the medical enter the legal? Like Carmen already alluded, we will watch people perform chest compressions on someone who's comfort care. And sometimes in the moment, it's really hard when so much is happening, things are chaotic, family's emotional. Not everyone's pulling out these representation agreements. Not everyone's, you know, they're relying on how they feel. So it's really difficult to navigate. I think ultimately that would be the way to go, to have some sort of formal process that's unbiased and protects the patient's wishes against unintentional and intentional biases. But I don't know how to operationalize that, yeah.
Questions about kind of twofold, and forgive me if I, everyone else knows the answer to this. So it goes back to the personal directive question, and a bit about some language I can use. So on the personal directive with the waivers, like, have you ever been legally challenged on that? And part and parcel to that, like I've heard you say the language that once a person gives you your mandate to end your life at a certain point in time, your person aside, you are legally bound to do it. I'm just wondering, from your perspective or from what you know of the legal perspective, are you actually, once someone says, I want to access the MAiD process, are you actually legally bound as a physician to go through with it? Or if you get challenged in court by an agent, what that intersection results?
No, it's a good question. I'd like the video will reveal all, but I'm quite certain what I said is I'm bound to this patient as long as they're legally eligible. That's a little different. I'm ethically bound as a physician and a public servant to see this through. I don't have to do anything I don't want to do. A patient could be a track one, very clear cut, and if for some reason I feel I can't do it or don't want to do it, I'm never bound to. That's actually in the waiver. It actually states as one of our clauses, I am not forced in any way or compelled to perform this. This is something I'm doing voluntarily and I'm signing this waiver. But it's not a legal document that says I have to do something. It's saying that I can do something. I have the power to do so without being prosecuted for homicide. But it doesn't say that I have to do this because the patient and I are in a legally binding agreement, only that I have the ability to make the decision and it supersedes a representation agreement. Have I ever been challenged? And the truth is no, but the truth is also, I very rarely do I have a patient fill in any kind of specifics on their waiver. Most of the patients tell me the same thing. If they can get me back, give them a chance. If they can't, do this as soon as possible. It's almost always what I hear. We'll have a talk about dementia because that's the one time it's not that. And every single time I talk about the waiver, it is a much longer conversation and it's a much more complicated conversation. So to answer these questions, I've never been challenged. I keep it simple for the reason that theoretically I could be. I don't want a whole paragraph that, no, take no offense, that a lawyer is going to go through and just pick apart, you know? I'm not a lawyer. I'm not sitting there like, okay, make sure you use this wording and then make sure there's no error interpretation in giving family powers. No. Very simple. I just want to know, is there certain things that you wouldn't want me to do? Are there certain conditions that are non-negotiable? Keep it simple. Very simple. That's the instruction for that very reason. I would never want to be sitting in a court having, being, asked, did the patient mean this or this? I want to be very clear, very simple. And lastly, that no, there's nothing legally binding to me. I make the decision about my comfort. And sometimes, and that's the very real truth is, sometimes I'll find that I'm no longer comfortable with the waiver for whatever reason, and then I'll tell them we're not resigning the patient's lost capacity. I was just telling Carmen just this last year, after the years have gone, I've had to evolve how I approach a waiver and the discussions I have, because I've seen the consequences of certain decisions. And now I have much more fruitful, meaningful discussions about it. Just this last year alone, 3 patients have lost capacity and lost the waiver and are not going to have MAiD. And the sad thing is I knew them very deeply because I've been following them for years, and this is what they were the most afraid of. And so now I'm very clear about my guidance to patients about how you understand the waiver, how you utilize it, and what you need to do if this is really what you want for yourself. All right, Trudy. A 98-year-old who is currently in assisted living. She uses notes on the door to remind herself of events going on, and now she can no longer retain any new information. She states that she would never want the disease to be too severe, but as long as she can enjoy her family, she wishes it for more time. When I start to probe to see the severity of the illness, the patient states her memory is still really good, but occasionally she forgets names. Her family joke that it's mostly just her youngest daughter's partner because there are too many to remember. She's just had so many. When I asked how long this person had been a partner, the family states 5 years. This happens all the time. It's not that the family isn't supportive, it's that they don't see the truth of it, either because they don't want to or they're just not ready to. And so we go into some, no, not Teddy. Confronting the disease, and that's the other side of the coin here. They want this for their family member because they know how important it is to them. But sometimes the family doesn't see. I talk to families about like that boiling water analogy. It goes up a degree, and before you know it, the water is boiling over, and it's too late, and family didn't notice. It's acts of love, it's acts of grief, you want to just love and support, and you're devoted to this person, but you create this circle around a person, and before you know it, every single aspect of this individual's life revolves around your care of that person, to the point that you can no longer separate what's them and what's you. And the patient certainly doesn't know because the disease is so severe. And I've had those conversations where I'm sitting with the patient, they're telling me everything's fine, this is for the future, and I'm looking at them saying, I can barely find you eligible now. I think your window is about to close. If you don't do this now, you're not going to have access. One of the more nuanced discussions was this patient said, I never would want, to be taken care of. When I was speaking with the family, they're like, oh, she means long-term care. And then I said to the patient, I want you to describe to me the conditions under which you would never want to exist. I need to understand what you do not want. And she said, oh, it doesn't matter where I am. If I depend on another person to stay alive and they have to do everything for me, then I want my MAiD. And then I asked the family, are we about to introduce supports into this assisted living facility? Oh yeah, she can't. No. We have to have people here all day. They have to monitor her. They have to give her meds. They have to help bathe her. And I'm like, does she know that? And they're like, no, we don't tell her. And then we had the discussion, and it was very emotional and moving for the family. They had to confront in that moment that it was as bad as it was, and that it had gone to a point that their loved one didn't want it to get to. And we had to all have that honest conversation about, we're already here, and there's no further time left. Like, you have to decide for yourself. And again, I don't, I'm not omniscient. I don't know what 6 months will bring from now, but I've been doing it long enough to have an educated guess. And I tell the family, my guess is that if you push this any further, there's a really high risk that you're not going to have this option at all. And that's the balance that patients strike. I talk about it all the time. No one knows their last good day. What's the last day that you don't suffer, that the illness doesn't do or take from you what you don't want it to? The best you can do is guess. And this is the sacrifice you make. You have all your good days, but you have to suffer the bad ones because you took the disease to the very end. Or you lose it on some good days, but you make sure you avoid the thing you fear most, the suffering that you don't want to incur. The only problem with dementia is that once you've gotten to that point, you've lost MAiD more often than not. And so you have to make that decision. Are you okay to lose some of these days you have left, knowing that if you push it any further, you might not get there? And that's when you have to know, how important is MAiD to you? Some patients would tell me, no, it's okay if it doesn't happen. I'd be okay as long as I'm comfortable and my family is there to love me. I say, great, then we're okay. This is your decision. And some patients would tell me, like she did, no, under no circumstance let that happen. Then I have to tell them, I think we've reached the point that you need to start thinking about a decision. And this happens longitudinally as well. And that's where I was, getting into this talk about the discussion about the waiver. The waiver can sometimes give a false sense of security, especially with dementia. I sit and talk to families and I say, oh, we're signing it from a year. A lot can happen in a year that I am not privy to. Even if there's a safeguard and someone alerts me that it's time to re-sign the waiver, I can arrive and a patient can be drastically different to the point that they're unrecognizable. And that's happened as well. I'd arrive, I have the conversation, I realize, oh, this patient is absolutely suffering major deficits and is functionally not at all where they were a year ago. Why didn't anyone tell me? And then I talk to the family, and it's the same thing. They accommodate, they start navigating it together as a family in a unit because it's an act of love, but then they've masked how severe it is. This patient truly can't function on their own, but they're helping this patient function. And now I tell them, we've reached the point. I don't think I can re-sign this waiver, and we need to make a decision. And so these are the conversations I now have with families with the waiver, what we need to be looking out for, understanding the family. I tell them, you don't need to have a MAiD talk. You need to have a talk about goals, about values. You need to understand your loved one the way that I'm trying to understand them. What will they not tolerate? What's non-negotiable? What gives their life meaning? What do they value? And what is their biggest fear when it comes to their illness? And then the family, knowing those things, can inform how they approach their loved one and how they have those honest conversations. Once I talked to the family about, no, your loved one isn't afraid of just a facility. She doesn't want strangers in her home taking care of her. The family knew that it was time, and they're already, trying to have these discussions with her now about what do we do? How do we navigate this? Is it really time? You just have to help people have those conversations that no one wants to have, which is, at what point do you think this life is not something you want to continue with? Because that means, at what point do you want to say goodbye? And some people aren't ready to have that conversation.
Boris, I hate to interrupt. We had this scheduled for 1:30. We're going to lose the room soon.
Oh, okay. Yeah. Let's do it.
So I just wanted to make sure that we were keeping on time.
Oh, it's my last slide. Now we're here with Teddy. 56-year-old retired professor, has early onset severe dementia. He has managed at home for a time, but is now becoming more forgetful of names. When discussing re-signing a waiver, the MAiD physician states that they likely will no longer retain capacity for that much longer. The wife states that they have the waiver in place, so even if capacity is lost, they can still move forward. They're just hoping for more time. The waiver does not protect against certain things. And a lot of people take issue with this term. Again, my opinions only. I love the term. If you ever practice medicine, you know a good death, you know a bad death. We have seen things I just never want to think about again, never want to remember, never want to talk about. And then I've seen things that I would want for myself on my last day. And I talk to patients about what they want that last day to look like. Losing capacity means you might not know who your family is, you might be scared, you might be confused. One of my favorite moments that I ever had was when the wife told me, we can hold this on a little bit longer, we have the waiver. I asked the patient, how would you feel if in your last day you didn't know it was your wife holding you? And he said, absolutely, that would be the worst thing I could think of. I want my last moment to be with this person that I love more than anything. And that helped him understand that it was time to make the decision and to go ahead, because he was already forgetting her name. You have to understand the person, and you have to understand what that last day is going to look like to you and what you want. And then that'll help guide you. And that's all. Thanks, guys. No room for questions.
I'll come quick.
Yeah.
Sure. So thank you very much for being a part of this. I know that there's been a ton of questions throughout the presentation as well, but knowing that we're on a tight time frame now, any additional questions for Boris or Carmen? Oh, great. So I guess you guys answered everything that came up throughout the presentation. So first of all, thank you to everybody for attending this presentation today. Special thanks to Colleen for helping set this up. Happy to be in partnership with CBA to put this on every October. Really appreciate you spending some hard-earned time with us today. So thank you for coming out. And a very special thank you to Boris and to Carmen for lending their time and expertise to this discussion. I have had a couple of questions, which I'll pose to you right now quickly. As people were leaving the room, is it okay to share the slides with the folks who are here today?
Oh, darn, the presentation, yes, but unfortunately the slides, no.
Okay.
Yeah, sorry.
So we did record the presentation, so we will end up sending out the recording. So at least you'll have that to go back on. We'll also likely post this on the ecfoundation.org website, although soon to be ecf.ca. That's a sneak peek for later. We're doing some rebranding, so stay tuned. But other than that, thank you all for being here. Thanks to the two of you for spending time with us, and enjoy the rest of the afternoon, everybody. Thanks very much.